Good evening, everyone. Am I audible?
Yes, you are right. Yes.
Yes.
Okay. Okay, we'll begin. It is a real pleasure to welcome all of you to the second step of VKR lecture series organized by the Humane Care Expert Committee of Sri Lanka College of Internal Medicine. As you know, medicine is a science, but there is also an art in it. Our committee is focused on that art, human side of care. We are proud to be led by Dr. Ganaka Senaratne with the full support of our current president, Dr. Kishant Jayasinghe, and the council of the college. Today, our session is on a very important topic. Beyond diagnosis, practical steps for more humane care. That will be delivered by an esteemed speaker who is an eminent clinician and also an expert in this particular field. Before we begin, I would like to mention some housekeeping announcements for the audience. Please make sure your microphone is muted and your video is turned off during the session to avoid any interruptions. A QR code will be displayed shortly. You can use it to access a Google form. Please note this QR code will remain active only for 2 hours after the lecture ends. We kindly ask you to complete that form within that time. Those who complete the form will receive a certificate with CPD points within 2 weeks. Now, I would like to cordially invite Dr. Kishant Jayasinghe, President of the College, to welcome the speaker and the audience.
Thank you very much, Rohita. It's good evening. It's with great pleasure that I welcome you all to the second installment of the VKR webinar series organized by the expert committee of the Sri Lanka College of Internal Medicine. As we continue towards excellence in clinical practice under the overreaching vision of our one nation, one standard, this series reminds of an equality in vital dimensions of medicine, the human connection. Beyond protocols and diagnosis lies a fundamental need to treat not only disease, but the person who bears them. As Rohit very correctly mentioned, today we are deeply honored to have with us a vision in the domain, Professor Saroj Jayasinghe, the Emeritus Professor of Medicine and a pioneer in advocating for compassionate, patient-centered care. His talk today, Beyond Diagnosis, Practical Steps for More Humane Care, promises to inspire us with practical insights into that can be embedded into our day-to-day clinical practice. On behalf of the college, I extend my heartfelt gratitude to Professor Saroj Jayasinghe for accepting our invitation and for his continued contribution to the ethical and humane practice of medicine. I also like to thank Dr. Ganaka Senaratne, the visionary leader of the expert committee on humane care, with his able members for their commitment and dedication in shaping this important dialogue. And to all of you for joining us today. May this session be an enriching experience that strengthens our resolve to treat with both skill and empathy. So let us now begin, and over to you, Rohita.
Thank you, Dr. Jayasinghe. VCare lecture series was initiated by the Human Care Expert Committee with the vision of bringing humaneness to the bedside. I would like to invite Dr. Ganaka Senaratne, head of the committee, to elaborate this idea further.
Good evening, sir. Good evening, Krishanta. Good evening, all of you. Thank you, Gamlat. And as Krishanta said, and this is we thought this is very important aspect of our practice. So we've been working as the expert committee since 2022. And our objective is to bring humaneness to bedside. And I must mention all the past presidents and the councils who supported this, our expert committee, right throughout since 2022. This year, we have organized several activities. We Care lecture series is one among them. And furthermore, we have plans and we are working on preparing a booklet, doing some qualitative researches, establishing a workshop, a practical workshop for our members and juniors, and bring a system to identify and appreciate and recognize our members and healthcare professionals who delivers this aspect of care are among some projects that we've been discussing in our committee. I must mention the enthusiastic support, commendable support provided by the current president, Krishantha, and the council. And of course, my own Humane Care Expert Committee members. So that's a blessing, actually. And I'm so happy to witness this second episode, which is delivered by our own advisor and our own committee member, Professor Saroj Jayasinghe. And I heartily wish that this webinar would enrich all of us and finally help Sri Lanka College of Internal Medicine to bring humaneness to bedside. Thank you very much. Over to you, Rohit.
Thank you, Ganaka. The topic today, beyond diagnosis, practical steps for more human care. It is a time reminder that good care goes beyond identifying a disease. It is about truly seeing the patient, their fears, their emotions, their background, and even their dignity. In this lecture, we will learn how to bring more humanity into our day to day clinical practice. Human care is, of course, not abstract, it is a practical and real world approach that looks at a patient as a whole person, physically, psychologically, socially, and even culturally. Tonight, we are truly honored to have with us Professor Saroj Jayasinghe, Emeritus Professor of Medicine, who has been a kind of a champion of patient-centered care throughout his career. Of course, he is the one pioneer to inject the humane care into the clinical practice of physicians in Sri Lanka. Therefore, I am confident Professor Saroj will share thoughtful, practical steps we can all apply. Over to you, Professor Saroj Jayasinghe.
Thank you very much. And it's indeed a pleasure. And I'm very grateful to the college, Krishantha, Ganaka, Rohita, and the team for inviting me to deliver this second lecture in the series of We Care. May I share the slides, please? Can you all see my slides?
Yes, sir.
Wait, let me know.
So just go to the presenter.
That's right, yeah.
That's right. Okay.
Yeah.
That's the answer, right?
Right. Okay. Yeah. So it's in a sense work in progress on the practical steps we need to think of in more humane care, because it's very easy for us to say humane care and humaneness and so on, but these are difficult to explain to others, and it's difficult to get people to follow certain things unless we define it and describe it, or explain to the person on how to realize it themselves. It's difficult. So in a sense, this sort of topic is something which will progress and develop as we go along. And the other important point I wish to make is that we are at the crossroads of AI challenging everything we do. And this may be the last frontier, because AI will take over most of the information processing and data which can be gathered by examination, by blood tests, endoscopies, and so on, using modern techniques. An example is if you would hypothetically think of a scanning machine which scans all the structures and is able to give the blood flows through Doppler. And basically, you'll be able to look at the structures in the body and the blood flow and the cardiovascular system examination, respiratory system examination, all will change. So in a sense, we don't know what's going to happen over the next few years and certainly few decades. But humaneness and being human and humane, being kind and so on, will still remain with us. So I think it's a good investment for us to start looking at this area, because the machines are going to take a long time to do what we can do. The machines can mimic empathy and so on. There are studies on that also, and sometimes they seem to be communicating and responding better than humans. But the human being on the other side knows that it's a machine. And that's going to affect the way you relate to another object. So I think this is, in a sense, thinking futuristically, this might be one of the areas which we have to develop further and take on the challenges which we will see with AI. So I want to start with a definition and a few examples so that we get to grips with what humane care is. And I'm very happy that the college has embarked on this and has used this term, because as Sri Lankans, we will be able to develop this theme further. And I hope to look at a process to develop the framework. And then we discuss a draft of how it can be applied. And a few future points also we can discuss. So this is a very simple example. A lady comes and says, I haven't brought the clinic book. And you can see two responses. The maroon response is something which really happened, unfortunately, where the doctor virtually shouts at the patient, what level of education have you completed? Why do you do this? What do you do for a living? Right? And something educated people would not do. And you can imagine how it affects the dignity of a teacher, a retired teacher who has trained generations of children. Or on the other end of the spectrum, you might find a doctor who says, oh, that's okay. Don't worry. Tell me, what are the medicines you've taken? Anyone at home, can we phone and find out, or you can even message them, ask them to send it on WhatsApp, your prescription. And let's work out how we can manage today's clinic visit. So you see, technically, legally, in a sense, the maroon response the person has asked some questions which are not humane. So, it's difficult to pinpoint and say what's wrong in it other than the humane angle. Because you can turn around and say, no, if you don't bring the clinic notes, doctor cannot be responsible for what the prescriptions are. He doesn't have a record of what medicines the person is taking. So therefore, it's within his rights to refuse to proceed with that patient's clinic interaction. You can give another date for the patient to come, right? That might not be a good argument, but that's what happened in reality. So when you look at this spectrum of responses, you find that this relationship between doctors and patients can be very dominant, or it could be not really dominant. Now, this was an example of a dominant relationship. Doctor is dominating the whole discussion. It could be a doctor-centered relationship where the patient is told, I cannot see you today because we don't have the notes, so we may have to see you on another day. Or a more patient-centered one where you try to obtain more information from the patient and sort it out. Or a more humane way where you understand why the patient has forgotten in her rush to come to the clinic. The fact that she might even may have some memory loss, we don't know, or it might have been some situation at home which made her forget it. So we are looking more at the person and the human care. Now, the problem we have is, as trainers and clinicians and as medical teachers, is to really find out what is this aspect of human care, which we have to look at. What are the competencies? What are the contents? What are the points? How will you decide one encounter is humane and another encounter is not humane? We know it almost by instinct, when you know when a relationship is good or bad. But how can we teach it to our students, to our colleagues? And how can we, if at all, even quantify it to some extent? Because we should be able to say a person is humane enough to be let out to the community. So how do we grapple with this challenge? So now these are few attempts at defining. I'll give you 30 seconds to read. So generally, I think most of us are between doctor-centered and patient-centered, right? We oscillate between the two. When we go overseas, we tend to be more patient-centered. And there could be a number of reasons. I mean, if you are seeing 8 patients for a whole morning session, you can certainly be more patient-centered than when you have a crowded clinic where you are seeing 40 or 50 patients. Okay, so we do oscillate between the two. Doctor-dominated one is something we should avoid at all cost. And if we control our anger, our temper, and our mouth, we can avoid going there. So I think we tend to oscillate between doctor and patient-centered care. But what is person-centered care? So I look at the person, and this is a definition given by the Global Health Commission by Lancet, which was selected just a few months ago, and it's starting work. It has already started work. So a person-centered, the concept is to look at the individual, the human being behind the patient, or the patient or the illness is embedded in a human being. And we try to look at that person. And then the focus is that person. The focus of a person-centered health system or a people-centered health system is to have the person's priority, the comfort of the human being, the comfort of the mental and physical comfort of the person is given priority. Now, in our setup, we are so rushed and we have so many patients and we have so much of stress in relation to numbers that we compromise on this. So we are very good at giving the technical ones. We see the treatment, medicines, devices, drugs, interventions, but we don't have much patient comfort. We don't have places for them to even relax a bit in hospital. We don't have a good canteen for them. We don't have a place for them to have some sort of peaceful discussions with their relatives, because we haven't been able to prioritize that. So, but if you're person-centered, the health system will think of those also. We can't blame anyone for this, but that's how it has evolved. And because you need more and more investments to shift to a person-centered health system also. So what is humane care? I've given in red text some of the points which are different in humane care from person-centered care. So it's still that the person and the people are at the center of the health services. And we recognize them as individuals within their community. So the household, the importance of the family, the household must be taken into consideration, especially in our part of the world. And there's a qualitative angle also, that they should be addressed with kindness. You see, in person-centered, you will see that it's very technical sounding words which they have used. And they haven't really talked about the emotional angle. And I think that's something which differentiates humane care from person-centered care. Now, I'll give you a few examples. Again, now our challenge is to tease out and find out what this humane care is. So I thought I will give you all a few examples, and then we will try to figure out what are the elements of a humane care. Now, this is a story of I'm giving a very abbreviated version. 72-year-old lady living with her 2 children on the 3rd floor, finding it difficult to walk. And well, 3rd floor in flats, she has to come to hospital every month to get her medicines. Now, there is a problem. If you really speak to her and you listen to her story, and you ask her, why is it difficult for you to come? Then you will get more details, right? Because this person is living in the recently developed flats. And in some of these flats, they don't have the lift till the 4th floor, right? So if you're having osteoarthritis or a stroke, you're virtually isolated because you cannot walk 3 floors the frequency you want. So you are isolated. So now that will bring in a whole set of problems to this human being, including access to medicine, including her mood, including her social networks, including her well-being. Right? Another example, a mother of 2 who is complaining of neck pain. Well, reasonable, there's no obvious cause. She says there's some pain in the neck, and it's quite severe. She doesn't do much work, looks after the children, drops them at school. Again, you have to listen to the story, and this rule of silence in the first 2 minutes is very important. And they come out with their story, and then they will give you more and more information, and you generally build a rapport. And then you ask, how do you take your children to school? Right? And that helmet is about 2 kilograms. So you immediately thought of another simple cause for pain in the neck of this lady. Okay, so another one, this was again, this was some time ago actually, I saw this patient. What was odd was that she came with her brother, and she came and said, I want a CT of the brother was saying, sir, අපි CT එකක් කරමු. කරන්න ඕනද? Because she's having recurrent headache. So now no features of migraine or anything. And the brother was suddenly, when the lady went to the examination couch, the brother indicated that එයාට ගහනවා. You see, it's a case of domestic violence. The CT was normal, but she was getting assaulted by the husband. So the brother brought the sister without telling the husband, because they were worried that she would have suffered brain injury. Okay, so again, it's the person. It's this is again the person coming out. The person embedded in a household where there is domestic violence. It's not a person with history of headache of 6 months. You have twisted the whole thing, right? And this was a patient who came with, it's related to rapport, because he came with severe pain in ankles and knees, with due to chikungunya, came in a wheelchair, and I spoke and asked about the history. And he was a Muslim gentleman, so I asked him, what about praying? Immediately, the relationship with the rapport built, because he said, "Ayyo, doctor, ඒක තමයි ප්‍රශ්න දැන් නම් යන්නෙත් නැහැ," because they have to, you see, unlike other ethnic groups or religious groups, they are more, they comply with that religious requirements of praying. And the males often go to the mosque. So for him, he was distressed by that. And the moment I said, no, you can't, it's difficult for you to go because you're having pain, the rapport changed. Not only that, he felt relieved, because here was the doctor also advising him not to go. Because you see, with chikungunya, you would have seen, there aren't many signs. I mean, you might see some swelling, but the symptoms are far worse than the signs which appear. So a person can always say, you don't have much arthritis. I have more arthritis. I have joint swelling also. Why aren't you moving around and walking around? Finally, another crisis. Sometimes you have to meet these people who come and want a letter from you for blood pressure. Before traveling, they say they want a letter. And then you realize that there's a huge story behind, because they are from very poor families. They have pawned or mortgaged and to these travel agents who have got them a job, and they have to go within 1 week or 2 weeks. Medical has to be passed. If not, they will be refused. And then if there's a delay, they have to cough out the money and it becomes a big problem. Okay. And this is the issue we see with people who are going overseas. Now, all these pictures are from the public domain. None of these have been taken by me. This is in fact from a newspaper, right? So you find this sort of situations, you come across, and you find that there are areas or aspects which we have to look at in a person which goes beyond the medical diagnosis. This is in order to understand the person. And here's another example of a person who was labeled for poor adherence, right? And only if you speak to the person that you understand why they are not adhering, because the floods have taken all their medicines and their prescriptions. Everything has disappeared, destroyed. So all this shows, these are examples, and all these indicate to me certainly, and to some of the clinicians, that we need some sort of framework to understand what we mean by humane care. We need a framework. So what's this framework? That's the challenge we are facing. I don't have all the answers, and I feel this is why I said it's work in progress, because this is an area which we have to tackle, and I've tried to tackle it, set of certain, written some proposals or thought through some proposals of a framework. Because we need this framework to get those who are interested to become more humane, to learn, and to be able to describe humane care in concrete terms, and also to assess, because if you are to assess, you can always argue and say we need not assess these sort of attributes, but then there's another strong argument that we have to assess some of these. The problem with assessment is you try to behave to fit the assessment rather than changing as a person. Agreed. It's well taken. But at the same time, from the point of view of the person, the patient who is there, they want a good human being, or at least a human being who acts to be a humane person. They don't want a rough person to speak to them and not to, not to look after their care. So it's required. I think it's required. And the challenge is how to do it. So what's the basis? Now, if we are, as a college, if we are to look at a basis, we must look at the history of humane care, humanistic medicine, humanistic psychology. What do the religions say about it? What are our value systems saying about it? What are our patients saying about it? And then try to develop a framework. So if I'm to look at some of these points, in the Western or the modern medical systems, humanism in medicine was championed, especially in the US, with people like Osler and Peabody, who spoke about the person. You would have heard these quotes. Osler's famous quote: "The good physician treats the disease, the great physician treats the patient who has the disease." Of course, we can now say that the legendary physician will get the person who has an illness. Then Peabody came up with this publication, The Care of the Patient, in 1927. The secret of the care of the patient is in caring for the patient. So the secret of the care we provide to a patient is actually caring for the patient. If we care for the patient, we will care for the patient, right? So it's that caring attitude is the secret. So this is a very important publication which changed the way medicine was practiced in especially in America. Around again in the latter part of the 20th century, this humanistic psychology came, because psychology at that time was dominated by behaviorism. So you're basically an animal, Pavlov-like animal, responding to reflexes, right? Or you're a person who has id, ego, superego, and the sort of crisis and corrupt interactions you have within you, like what Freud described. In all these, behaviorism as well as psychoanalysis, they didn't talk about the goodness of the human being. So humanistic psychology, Carl Rogers was one person, and you may remember Maslow's triangle, okay, where after looking after the basic needs, basic security and friendship and so on, you want to develop as a person, self-actualization, right? Creativity, spontaneity, self-esteem and so on. So in all these, you're trying to say that there is a person who is there, who has got some illness or symptom or disease, and the importance of the person. So humanism in medicine, humanistic psychology, and philosophies like phenomenology, which respected the first person's point of view, first person or subjective point of view. And you see this even in mindfulness and Buddhist practices, where you respect person's inner thoughts. You can't ignore it. And for years and for decades, Western philosophies and Western psychology ignored it. Behaviorism ignored it. And all these are threads which show that the thinking, feeling human being must be respected. The thinking, feeling human being who wants to improve his or her situation must be respected, must be the dignity of that person must be ensured, and so on. So to go back on religion also, this respect of the individual given in Vinaya Pitaka or in the Holy Bible and so on, do unto others as you would have them do unto you. So you respect the person just the way you want to be respected. Or in Hinduism, the Vaishnava characteristics of respecting the other human being. So religions also have it. And when you try to apply it in healthcare, we see several publications of it. And this is a recent publication 2 months ago. I authored this. This is on people-centered care. Now, looking at different elements of people-centered and person-centered care at 3 levels. At the individual level, right on top, that's our clinical practice, and that's the focus today. Or you talk of institutions like clinics or hospitals, and the whole system, health system, which can shift towards this people-centered, person-centered, or humane aspects, incorporating human aspects of care. And there are other conceptualizations where you have looked at it from a structure process outcome model. And in the process, you will see patient healthcare provider level, cultivating communication, respectful, compassionate care, engaging patients in managing their care, integration of care. That's you, so that right now we have disintegrated services. Cardiology clinic on one day, neurology clinic on another day, and the metabolic clinic on another day. So we don't have this multidisciplinary concept. So these are attempts at giving some frameworks. But what we find is, for the clinician in front of the patient, right? What do you mean when you say humane care? Now, for that, we have got a few examples. I showed you a few examples. But what's the framework? How can I teach someone else, this is what we mean by humane care? So let's get to that stage now. And for this, we have used the Sri Lankan experience, because in the Sri Lankan experience, one transformative change, and I urge and plead with all medical faculties to do this, and that is to ensure that your students visit patients after their discharge. This is not to be confused with community-based attachments, family attachments, GP attachments, and so on. No. This is where the person comes to see an internal medicine specialist, recovers, and goes home. So it could be a stroke, could be heart failure, it could be any of those disorders which brought the patient to the hospital. But when they come to hospital, we are very disease-oriented for a number of reasons. It's the numbers we have to tackle, the physical issues which have to be sorted out, and the person becomes a less of a priority. But when they are at home, it's the person who is priority. And you see the person. Okay, this is a picture from India, actually. They are using volunteers who go and see patients at home. But this is the sort of environment we have seen in and around Colombo, right? And you can imagine houses with one small window. And when students say to reduce dust, you have to cover the mattress with polythene, how absurd it is, because this low-income settlement is right next to a main road. And you can't reduce dust by doing anything. It's almost impossible, right? So to understand the circumstances and the person and the human being who has to cope with an illness can only be achieved by these home visits. It should be there, I think, in all specialties, undergraduate and even in postgraduates. I think that's the way forward, because increasingly we need people who have human attributes. They will learn to be person-centered with this, and we cannot have people with chronic diseases visiting the hospital for all their needs. We will have to shift some of the care to be given when they are at home. So home visits showed us so many areas which we had not even thought of. difficulties in mobility of patients, you can't appreciate it unless you visit their home. The fact that 3 people are sleeping in a room, you cannot appreciate that when the person is in the hospital, right? The lack of windows, just one small window, risks of falling because of the structure of the house. Criminal activity, we say do exercise and walk, you can't, because in some areas there are gangs or people who are, if the area is in a small corner, you can't ask them to be moving around much because it's not safe, right? Then environmental hazards we never even thought of. Narahempita, the children are playing just near the train track, and we are treating dengue where the household is surrounded by blocked drains, not cleaned by the municipality. Or a person having respiratory illness living near Mitotumulla, waste dump. So only when you visit homes that you see the problems faced by human beings, the person. And it's an eye-opener, and it helps us to develop a framework. So we look at all these, including the different aspects given here and the experiences, to develop this checklist, as it were. It might not be complete, but this gives you some of the points which bring out the person. So usually it's the clinical diagnosis we are focusing on. But remember, a good clinician will look at ADLs, IALDS, frailty falls, incontinence, sleep and appetite and so on, and also may bring in about the transportation, caregiver, health provider, and so on. Right? So these are fairly well-known sort of elaborations of the health issues. So a humane person looking at health issues will look at these other facets. But we all know how novices, how students will be thinking only of the diagnosis of a disease, not really worried about the physical functioning of that illness, the effects of the physical or of the illness on the physical function. So they will focus only on the diseases, right? So it might be a stroke and you are not looking at the ADLs, okay? So if you look at other aspects, you find a whole list of issues, right? The common ones are tobacco, alcohol, drug use, but exercise, recreation, access to healthy options of food, sexual activity, sexual orientation, domestic violence, marital status, children, elders, in psychological identity of the person, because they lose their dignity when they are, a person who has a cancer, immediately their view of their identity changes because they feel they have very limited time to live. And, you become treatment, you become a cancer survivor, another new identity, right? Then this idea of ideas, concern, and expectations, which has now come into our jargon. Emotions of the patient. Are they worried? What are the worries they have? Not necessarily depression and anxiety, which are more disorders. Emotions are normal emotions. To be worried and to cry when you know that you have to that you have to wait for 2 weeks in a hospital to take some drugs is normal. It's not depression, right? because you know that for 2 weeks, say, there's going to be chaos at home. Right? But then, of course, suicide risk, stress, burnout, and so on. Social issues also came out, and in some of these interviews, we found, we look at the occupation, we'll ask them the income, but we don't realize that some have pawned their jewelry. Others have mortgaged their houses. We have seen people who are spending, who have lost almost everything because they went for an ill-conceived transplantation, right? And they lose whatever they have. So these are aspects which you see, which we should be looking at in the case of identifying what we mean as humane care. An area which we tend to ignore is the cultural, the ethnic and religious issues, and certain beliefs in social groups, right? And for example, I mentioned about the prayers. See, in some religions, you don't want the female to be touched by a male, right? So how do you, in such situations, sometimes you might want the husband to be close to, in addition to a chaperone, right? Or you might move the screen so that the husband can see you with the wife, if the wife doesn't mind, right? So there are things like that. And then our own values. I have mentioned this before also. I mean, when a clergy, we see in the temple, we worship, but in the hospital, we ignore. Right? Do we stand up when an elderly person comes? I do. And when the person goes, if it's an elderly person especially from a village area, you just do this and they will also reciprocate, right? And they might say, "Aibowang," or "Teruwan Saranai," or whatever, right? So these are cultural issues, and we should do these. These are respecting the human being. If you are prepared to say, "Good morning, how is the weather in UK?" I don't see why we can't do those in our culturally appropriate behaviors in our own cultures. Another area which, if you really want to understand the person, is the environmental issues, because I mentioned about garbage, the pollution, and so on. But it becomes important, flooding, recurrent flooding in certain areas. So you have to accept the fact that some of them cannot come to the clinics the way we want them to come. And people have to be given, you can't label them as having poor compliance. So if we bring in all these, this is a sort of a framework. Right? Now, in our traditional, conventional history taking, you can remember, no? You talk about the medical problems, presenting complaint, the identity of the person and all that, past history, past medical history, and so on. So that's all medical. Then you talk about the personal history, the person's habits, cigarette, alcohol, blah, 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 such and such a job. And then you say social history is living in such and such area, can get to hospital by train or by bus, and is doing work and financially okay, and blah. But I think we have to stretch those. So in addition to the personal, we'll have to add things like psychological there and make it explicit. See, we can't have these hidden explicitly. So the person's emotions, are they in psychological distress? What about in a person who is depressed? Yes. What about suicide risk? Right? What about anxiety and so on? In the social, we have to explicitly again include culture, include environment. So culture, what about the ethnicity? What about the religious beliefs? Are we respecting? Right? And when it comes to environment, the household environment, the community environment, how is it impinging on the person? So what I feel is we can extend what we are doing now by using this conventional description of medical issues, personal and social, by pushing it to a sort of a hexagon where personal and psychological, social and cultural, and environmental aspects. Because if you bring in all those, you will be giving a better description of the human being. And in the examples I gave you at the beginning, at the very beginning, those were examples of the person being important, right? So we had about the staircase, the stairs, we had about domestic violence, psychological, we had social aspects about the person who was going abroad, we had the chikungunya affecting a person who used to pray regularly, and we had poor compliance in relation to drugs because of floods. And personal, I put a yoga because I distinctly remember another story where the lady of 30 odd was complaining of neck pain with a radicular pain, and you generally want to get an x-ray and so on, and person was just going, and this was some time ago when yoga was not practiced often, right, about 20 years ago. And I just happened to ask, do you do any exercise or yoga? Yes, she said she used to do the headstand, right? And if I didn't get that history, you see, because she underwent emergency surgery, she could have ended up a quadriplegic. So these are examples of looking at the person. And you will see it's not a magic thing which we are trying to do, but it's a change of focus from a patient or an illness or medical, personal and social to different aspects of medical, including functioning, personal aspects, as well as psychological aspects, social and cultural and environmental. And these are the examples which we discussed. Now, if we are to apply this, we can apply this as a clinical encounter. Now, shall we have a few questions at this stage if you want? How am I for time? Have I gone? Oh, it's almost 9:30. Gamlat, Ganaka, do we discuss a little and move on, or?
So this is very interesting. I think you can move on.
Right. Okay. Right. So now the next section is how to apply this to a clinical encounter. So you see, we for convenience we have history taking, physical examination, arriving at a diagnosis, and treatment. So can we apply this framework? And I've tried to do that in this apply this to the clinical encounter. So if it's a human clinical encounter, we should have the generic competencies of kindness. So whether we are examining, whether we are doing a human history taking, or whether we are looking at a holistic care or comprehensive diagnosis or investigations or whatever, there will be a certain generic component of kindness which we should promote, right? And then when it comes to the clinical component of history taking or physical examination, we can use our hexagon as a guide, or you can develop your own mnemonic, it doesn't matter. But trying to look at some of the areas where the person comes out, right? Now, kindness also is difficult to define. And we've looked at several definitions and descriptions of it. And this is one definition of being sympathetic, helpful, wanting to bring relief or happiness to others, and expecting little in return. I mean, it's not an exchange when you're being kind. You're not expecting the person to be, I'm being kind with the idea of getting back something. No, you do it at that stage because you want to be kind, right? So that's something which we have looked at by doing some in-depth interviews, and preliminary results have been published. But what we came out with, well, these are some of the points they made. Listening. Talking to the patient makes you talk to them nicely. Explains. Comforting and kind speech that is slow. Tone is very important. You can tell the same. This is why we don't use the term please. We don't say please and sorry so much, because sometimes from the tone itself we have mentioned please, right? And these are language, this is the language we miss when we translate everything into English, okay? So actions, so speech, but actions also they watched, because these were patients who were in the wards, they saw the doctors behaving, right? So people who were patient, who were dedicated, they knew. කන්න වෙලාවක් නෑ අපිව බලනවා doctorsලා. You know, how they look up to, and how they might not express these. Only when you ask them to express, they will do, right? කෑවද බෙහෙත් ගත්තද කියලා නිතර අහනවා. Those out of the way to help. Okay. So if you are talking of a humane history taking, you will have certain competence of kindness. And these are the usual points in good communication. You see that these are overlapping. Silence, active listening are of, initially you must allow them to speak. And this non-medical question is very important, because I told you last time also, I think, if a patient comes from Tambuttagama, you have to ask, Janadipatike Gegavada, right? And you see immediately that, because that's his identity, that person's identity is from that area. And you're showing, you are, in a sense, you shouldn't think of those as, this is not PR. This is not PR. PR is where you do it with that intention of gaining publicity. No, this is your acting like a human being who wants to make conversation. The same sort of interaction you would do when you meet someone, you go to a conference and meet someone, you have to have some rapport. Okay. So two-way conversation, non-jargon speech, appropriate tone, very important in Sri Lankan context. Summarize, allow people to tell that he saw her story, and then you use the model. By this time, if they come out with most of these, they come out, and this is where the art of medicine comes in, because once you'll see how the experienced physicians would be specialists, would ask the relevant questions without a framework. If you ask them what's a framework, they can't figure it out. Because they have developed something and it has become part of themselves, their being. And you're asking questions which are natural to you, and you're getting the relevant answers, right? But when you're a novice, we have to give you a framework. With time, you will move on. You develop your own frame. So you will start having the kind generic these things, but then you might have like the review of the systems we do. You might have to ask a few key questions based on your assessment, right? So, physical examination, again, similar, but there are a few other things. Showing respect to the person, dignity of the person, how much are you going to cover, how much are you going to expose, making sure there's a chaperone, right? Or the accompanying page. If it's a young girl, 14-year-old, 15-year-old, you're going to examine, even though there's a chaperone, get the mother if the mother is there to come. Because the girl is frightened, especially if it's a male who is examining, right? Then examination, eye contact is different from eye contact during an interview. Because you see, because it can be quite disarming because you're invading the privacy now. When you're examining, you're invading the privacy of a person. You see, you have to realize that we as doctors are constantly invading the privacy of other human beings. I mean, how many abdomens have you touched of females, we'll say? Males, females having touched males. I mean, a few 100,000. You take anyone, any other person in your family who has not done medicine and ask them, how many abdomens, ask your brothers, for example, how many abdomens of females have you touched during your lifetime? It will be probably only the wife, 1 or 2, right? That's the level of invasion of privacy which we do. So when you're even eye contact, it has to be very gentle. You might make immediate eye contact, and you might be looking at the face, not to directly giving eye contact, but to see whether the person is in pain when you're pressing the tummy, right? Especially when you're examining the chest, right? It is very embarrassing if you're staring at the person and trying to auscultate. Again, smile, again the same issue. Because this relationship during examination, a human examination is different from when you're speaking and obtaining a history. So permission, rapport, and all those are there. And the other important part of a human examination, I feel, is to give this commentary. See, when you raise the knee hammer, you know it's a knee hammer. But the patient doesn't know what the hell that is, whether it's going to hit the head or whether they are going to use the pointed part to check on sensation, right? So if you get used to that, where you say, whatever you are doing, you say, I'm going to listen to your chest. And that gives a rapport, and you get the patient cooperation. They become, they are quite comfortable with that. And you should always be asking about discomfort and pain and so on. So these are, again, the generic part, but when you are examining also, there you can use the hexagon in certain areas, especially when it comes to, elderly people, the touch you would do, and in certain cultures, you don't touch them, right? Holding the head, some wouldn't like that. But an elderly person, you might want to hold the hand, might want to help the person, and so on. So there are certain aspects in the physical examination also, which can be humane. Now, when it comes to the clinical, the humane care, which we are going to provide, there the generic aspects, in addition to the communication, would be where we share with them the goals we want to set, their ideas, concerns, and expectations, and then of course the certain non-medical solutions which we can provide with them. Involvement of the family. You should ask patients whether they want to bring in the family, speak to members of the family, and it has to be proactive. This idea that the Western model of speaking only to the patient, it doesn't work. That's an autonomous individualistic societies. Here, there's shared autonomy, and it's a more collectivist sort of orientation we have. So in the solutions, now they talk about this in humane care, they talk about social prescribing. So this is just an example from of social prescribing from the UK, and you'll see some of the points which I brought up in identified in the person, in the model, in the framework. See, religious community groups, parks, recreation, then a retired person, what are you doing after retirement, right? Social networks. Then children, what about sports? Okay. And so this has been, now they have talked about social prescribing. We might have to think of humane prescribing or whatever, right? College might want to think of something, but we should develop a sort of a framework which will help us as well as the future generations to use. So these are some of the examples of social prescribing they mention in the literature. Okay. Right. So now I'm almost finished. What's for the future? I think this is a long haul. Don't expect any of these to change things overnight. When home visits, it was pioneered by Professor Rizvi Sharif, probably 25, 30 years ago. And we called it social visits, social medicine. Then we changed it to home visits because social medicine has a different connotation. So we brought in home visits and bringing in this issue of care after discharge. And that took so long for it to have an impact. And it's slowly spreading to other faculties also. So what I feel is it's a long haul. This is just work in progress, and we have to get the views of people who are in the profession, outside the profession, specialists, and so on, and develop this framework. Then I feel we should have a consultative meeting at some stage so that there's a consensus, at least within the College of Internal Medicine, because that will form our training manual. That will be useful for us to run the workshops and training of trainers. Now, one very important point I want to make is what the College of Internal Medicine in Sri Lanka doing is, it's a pioneering thing. None of this is happening in the colleges in this region. You must take leadership in this, because this is what we can offer to the world. And I think we are well placed to do this and take this forward. You see, actually, you have to be proud of some of the facets of Sri Lankan society, which we rarely talk about. We have one of the highest per capita voluntary blood donation rates. We provide one of the We are the world leaders in providing cataracts free of charge almost. We have the highest, one of the highest breastfeeding rates, showing the importance of mother-child bonding in our culture. Okay. If you see, even in our medical education, you see how specialists are teaching students without a fee, right? I mean, we don't charge the universities. You all don't charge the College of Internal Medicine, full of specialists, right? You all teach the medical students. You know, it's done with a view to furthering the profession and as part of our obligation. Very few countries have done sellers like this. Even during the intense economic crisis, we had done sellers. Right? So there is something in our society. You'd have heard how during the Candy Perehara, you know, how the churches opened and gave food, how the mosques opened certain areas for female pilgrims to come, right? Usually they don't allow female Muslims to come, right? The Kovils open. That was during the Dhatu exposition. Those are not heard in the newspapers, not in the social media. So I think there is something wonderful in this country, and we have to use this opportunity. I think the college is doing a fantastic job in this. So congratulations once again. And I hope you can take this forward and enrich. This will be a lasting contribution to the world of medicine. Thank you.
Thank you very much, sir, for your inspiring and thought-provoking talk as usual. As I mentioned in the introduction, we hope to learn and appreciate the art of medicine, what we call human care. And I believe today's session truly delivered that. Because the number of participants in the audience remained steady even after the scheduled time ended, which clearly show how interesting the talk was. Now, I would like to open this forum for a few questions from our virtual audience. You may text the questions in the chat box or raise your hand, then we can unmute your microphone and allow you to talk. Please be kind enough to introduce yourself briefly before asking your question.
There is one question which I can answer immediately. That's on this, on the fact that hospital setup really lacking humane care. Actually, that's a very important one. I didn't want to deal with it because there isn't much time. But actually, you can bring in these principles even to your own wards, right? This is a slide which I kept in reserve, right? It's the sort of things which we can move towards, but let's discuss that later on. Yeah. Any other questions?
So there's a question, why the do not attempt to resuscitate is not in our practice, even we follow the Western medicine.
Yeah, I mean, of course, this is it's an interesting question. It's to do with the law, because recently at the Sri Lanka Geriatric Association meeting, there was a plenary by the Supreme Court judge, and he, Mr. Kodagoda, and he described the lacunae in the law. We don't have proper legislation. So he, in fact, gave out a very nice description. And this is something which colleges have to take on. And I understand the SLMA has a palliative care committee. I think Dr. Udayangani Ramdas was involved in it, Prof. Panduka Karnanayak, Prof. Percy Chan, and several others were involved in it. And now it has to go into a legislative form, you see, because having it as guidelines is one thing, but if you really want it to fall into legislation, then it has to be drafted, go to the draftsman, go to the cabinet approval. It can take years. So I think that's the reason why it's not being practiced and it's still not very clear. But the SLMA guidelines by the Palliative Care Committee on End-of-Life Care gives a good framework for practitioners.
Any more questions? So there's another question. How to balance empathy and humane care that has sympathy as part of it? I think
Yeah,
someone is asking the difference between empathy and sympathy, I believe, sir.
yeah, so I mean, empathy and sympathy and compassion and altruism, these are all similar but different concepts. So it's very important that we define these before we use it in a particular setting. Why I say that is, now even empathy, initially we talked about empathy as feeling what another person feels. So you're feeling those emotions. But then people talk about cognitive empathy. That is, you understand what the other person is going through, not necessarily feeling. So you see, these concepts have to be sorted out first, what your definitions are. But then the issue about empathy is how much of empathy and how do you prevent empathic distress? How do you switch to compassion, which means you feel what the other person is, you understand what the other person is going through, but your motivation is mainly to help the person out of that suffering or out of that distress. So you see, these are competing. I mean, it's a separate topic, as it were, if we were to tackle that. So one day we perhaps should discuss these in further detail. But the short answer is, it's the balance will depend on we'll have to first define what we mean and then try to balance. There are no hard and fast rules in these because it's a case of at one end of the spectrum, some would say, keep your emotions at home and come to do your work. And at the other extreme, you have a person who is crying in the ward because the a patient they were looking after has died, right? So that spectrum is there and the truth lies somewhere in between. Yeah.
There's another question.
Yeah.
There's another question, sir. One of the problems in giving humane care is that the carer himself is under stress or depressed or maybe autistic. How do you address this?
Yeah, so you see, when you are providing humane care, this is where the concepts of shared care, team care, when discussing with your team about aspects related to care, and after a distressing episode where you share the distress with others, all these become important because when you're otherwise, there are various technical terms being used. One is empathic distress. That's what happens to us at the beginning. You see, if you remember, I can still remember the first patient who died in the ward. it was terrible, right? And there was a lot of pain. And after some time that you start seeing so many patients dying. And again, I want to compare our experiences with another profession, right? A bank manager might never have seen a person die, right? But by the time we are hitting 40 or 50, we would have seen hundreds dying in front of us and having to console hundreds. So that has a toll. That has a toll. So that's what brings this concept of empathic distress. And that empathic distress, unless we tackle it, unless we try to where we feel, where we control our emotions, where we share our emotions and so on, unless those are done, the empathic distress affects you psychologically. That is why some people bounce back at patients, because they have become, when another person is in distress, it angers them because they have gone through so much of distress themselves, right? So they're rude. When a person is in distress, they don't try to alleviate the distress or find out why. They hammer back with various formulations, So these are things which we will see. Then we have compassion fatigue is another very similar concept. So if we are to tackle these, our health systems also have to change. We don't have any form of, if there is an issue with the patient, what's the support we have in the hospitals? Hardly anything. It's not in the system. We don't have an occupational system, occupational safety system even, which will help us or counsel us or anything. It's just the boss and one or two friends. So I think a long way to go to sort those out.
There's another question, so I think
Yeah.
there's a link to a previous answer as well. Is human care similar to palliative care?
No, you see, palliative care will be mainly related to utility of care, or at the end of life, or having a terminal illness. But human care is, even with an infant, newborn, at any age, you should be able to, your care should be humane. I think all forms of palliative care are humane, but human care can be wider and more comprehensive and involve the whole system rather than this particular groups of patients. Yeah. Here's another question. I hope I've answered that. Yeah. There's another question. Talking nicely but discharging prematurely without finding what's really wrong with the patient, and he's bouncing back with double suffering. So don't you think that correct diagnosis and accuracy in treatment, saving him, is also to be included? Yes, yes. See, it's the idea that it is clinical competency or compassionate care is wrong. Its clinical competency will include compassion or humane care. So it's both should be there. We should not be differentiating the two. We should make sure that they are clinically competent. If the person is, now in this example, what is our clinical competence is being questioned. So you are discharging prematurely because you can't make a diagnosis or something, or because you are having too many patients in the ward or whatever. Which is not within your control, but anyway, that's not the response, is not to prematurely discharge with the risk to the patient. So in such an instance, you cannot cover it up by humane care. I think both have to go together, right? So it has to be, if you are clinically competent, humane aspects should be there. Humane care should also include clinical competence. They're inseparable. This, I think, should be considered inseparable. Yeah. Any other questions? Thank you very much.
With that, I think,
Oh, there's one question there. Enough
Yes.
time and
Sir,
we can.
yeah, I'm Dr. Indika, I think psychiatrist in the team.
Yes, Indika, yes.
I
Any
want
question?
to ask you,
Yeah.
is, sometimes we want to bring some sort of ethical practices that we think is humane and we think is should be practiced in clinical care, but in the culturally, if those practices are not sort of to be they are not considered very significant, or the contrary is the practice in that culture. What do you think, sir? Sort of bringing what we think is ethical into the cultures where they don't think it is necessary, or we think that introducing these things are a bit of odd in such cultures.
Sorry. Yeah. Is there an example you would like to share, or you want me to ask a general question?
Yeah. Sort of confidentiality. If if you see that it's not in practice, and it is not also not a problem in those cultures, so bringing that practice, sort of sometimes feel like we are forcing or we are pushing it into the practice.
Yeah, that's an interesting question, because if you're if a person is we'll say a patient doctor encounter, and you want to think about confidentiality, but what you're saying is that the patient might not be so concerned about confidentiality. Is that right?
Yes, yeah. And also the culturally and the other staff and who are in that culture. So
Yeah.
let's say that in this, in Milwaukee, where this culturally in that society, if they're not considering confidentiality as a big concern.
Right. So there are, you see, that's an interesting situation, because you see, with the patient, it will depend on the patient's take on confidentiality. For example, right, you maintain your ethical standards, and you won't divulge, and you can tell the patient also. Now, for example, sometimes when children of my friends come and see me, sometimes I openly tell them, I won't be telling anything to your parents, so that then the rules of engagement are well known in advance. So with the patient, I think you can negotiate that. But when it comes to the institutional culture, that's a different issue, because the institution actually should, or the institution, if our hospital, for example, if a hospital is breaking confidentiality, that's against the institutional policy. Though it's part of the culture, it's actually they're breaking policy there, right? So I don't think we should have to fight with them, but it will take time. It will take time, and sometimes you have to you have to take certain precautions which to protect the patient. I can remember during the early parts of the HIV/AIDS epidemic, when we wanted confidentiality, but the institutional culture was not so. But we knew that the doctors would maintain confidentiality. The problem is when you are sending the sample with the report and the request. So we developed a system where in those instances, the doctors took the sample and took it to the lab. and there were some other ways they used. I can't remember all the details, what, 30, 40 years ago. But so you might, until the system changed and the culture of the institution changed, we had to use other strategies. But even at that time, the institutional policy was that confidentiality has to be maintained. So the short answer is, with the patients, it's a different situation compared to the institution. And in the institution, it's a case of negotiating with your colleagues and with the officials to agree to some basic rules. Some basic rules, yeah. I hope I've answered your question.
Yes, thank you. It's very complicated, and I was
It's very complicated.
yeah. It's good to initiate this dialogue. I want
Of course, yeah.
do it. It's very great chance to talk with you about these things. Thank you, sir.
Thank you. And Dr. Asela Anthony has asked, thank you, Asela, for the compliment. Some of what you said is taught in practice in family medicine. Yes, the biggest drawback I see in putting person-centered care into practice is not spending enough time. Yes, absolutely. Absolutely. So what are the options we have? Well, some options we don't have. In some contexts, we don't have control. So we can't reduce the admissions to the wards, right? But in certain areas, we might be able to give more time, for example, where you give more time to new patients, where you see the new patients separately, or you have strict, easily followed protocols, which will help to reduce admissions, or if there are preliminary care unit, the hospital works on that so that you reduce admissions and so on. So what you say is quite right. But at the same time, there are certain elements of humane care which you can do even with limited time. Now, the good example is in 2 minutes. We say you have to speak to a person in 2 minutes. You can speak in a very rough voice and very rudely, or you can speak very nicely. Now, that's part of the medical training. That's part of our professionalism. That's something we have to learn. That just because we get angry on a short fuse, we should not let it out on the patient, because we are not going to do that to our boss. Boss can be sometimes very unfair, but even you dare not shout back. Very rarely, if at all. But you see, that is because our executive functions are controlling our mouth and telling you, we use the correct words. This is you're speaking to the boss. But when it comes to the patient, we let go. So I think it's your point is well taken. But even within 2 minutes, even when you're rushed, you can still do it. See, now when if you're working till 1 o'clock and you want to have a cup of tea, the patient is also now there from morning. But if you tell the patient, මම තේ එකක් බොන්න ගිහිල්ලා විනාඩි 5ක් දෙන්න, they will appreciate it. Right? Whereas if without looking or eye contact or something and the person is seated, you just get up and go, he doesn't know why you have gone, he or she, and then that's not good, So I think we can do better with whatever we have. That's the sort of thing. Yeah. Any other question? Is there anything I missed? Autistic, yes. Discharging prematurely, yes, that we answered. Any other questions? Yeah.
With that, I think we are coming to the end of today's session.
Yeah.
Our speaker this evening was Professor Saroj Jayasinghe, Emeritus Professor of Medicine. On behalf of the Humane Care Expert Committee and the President and Council of Sri Lanka College of Internal Medicine, I'd like to express our sincere gratitude to Professor Jayasinghe, not only for showing us practical approaches to humane care, but also for reminding us of the deep satisfaction that comes from doing our job with empathy and compassion, and also for the suggestions given for the future. I also want to warmly thank our audience today, the council and the members of the college, medical consultants from various disciplines, trainees, medical officers, and students for staying so long with us and for your active participation. We hope to meet you again next month at the third session of our VCare lecture series. Good night, ladies and gentlemen.
Thank you very much. It's been a pleasure
Thank you,
interacting
sir.
with all of you. Thank you for giving me the opportunity.
Thank you, sir.
Thank you.
Thank you so much, sir. Wonderful talk. Learned a lot.
Thank you, sir.